Tell us how you recognize and manage hypophysitis associated with immune checkpoint inhibitors. Hypophysitis is a rare condition, but it can be a very serious endocrinopathy if it does occur. It may also be referred to as central adrenal insufficiency. The incidence, in most cases, these are going to be low grade, grade 1 or 2 swelling of the pituitary gland. However, the incidence of grade 3-4 does exist. It occurs in less than 1% of patients on anti-PD-1, PD-L1 inhibitors, about 12% in anti-CTLA-4 inhibitors, and there have been ranges from 7 to 17% with combination therapy. The first cases were reported in 2003, but recent studies are indicating that there may be a rise in incidence, and this may be due to the fact that we're seeing more combination therapies. There's some indication that there may be an increased risk in males and those that are greater than 60 years of age. The presentation of hypophysitis can be very vague, and that may lead to a delay in diagnoses. The symptoms may mimic other causes, such as brain metastases. The symptoms include headache, generalized malaise, fatigue, appetite loss, photophobia, and dizziness. The onset can be anywhere from 5 to 56 weeks. However, the median onset is about 9 weeks. There have been some reported cases of hypophysitis after discontinuation of treatment. The evaluation and confirmation of hypophysitis is going to be an MRI of the brain, but it's important to let the radiologist know that you want to obtain pituitary and sellar cuts. This will give you a nice image of the pituitary itself, which is often overlooked when you're having an MRI done. In some cases, there may not be any inflammation noted. However, the patient may still be symptomatic. Laboratory assessment includes assessment of the pituitary hypothalamic axis, which is the prolactin level, the pituitary thyroid axis, which includes free T4 and TSH, luteinizing hormone, follicle stimulating hormone, and estrogen for women, and testosterone for men. Also important to assess the pituitary adrenal axis. So this is going to include an ACTH level and cortisol level in the morning. Electrolyte abnormalities can be seen as well, so it's important to obtain a complete metabolic panel, which specifically includes potassium and sodium level. With hypophysitis, you may note hyponatremia, so a decrease in sodium, and also note hyperkalemia. In very rare cases, elevated pancreatic enzymes might be noted. The risk of having hypophysitis is that if left undiagnosed and left unmanaged, actually may lead to other endocrine organ dysfunction and permanent dysfunction of those organs. This may include secondary adrenal insufficiency, central hypothyroidism, secondary hypogonadism, and diabetes insipidus. Treatment is going to be based on the replacement of the organ that is affected. And typically, it's going to include hydrocortisone, which is 20 milligrams in the morning and 10 milligrams in the afternoon. If patients also have a secondary hypothyroidism, they might require levothyroxine replacement, and men may require testosterone replacement. Patients really need to be educated regarding stress doses of hydrocortisone in cases of infection or trauma or other stressors. In some cases, they may need to continue on stress doses of steroid for 24 to 48 hours until those other situations are resolved. In low grade or grade 1 or 2 hypophysitis, typically the management of choice is going to be to hold the immune checkpoint inhibitor for a short time until hormone levels can be stabilized. In more severe cases, it may need to be held longer. But once the grade of the toxicity has returned to grade 1 or grade 0 in almost all cases, you can go on to continue to be re-challenged with the immune checkpoint inhibitor successfully. Pituitary function may or may not recover, however. That is really not clear at this time.